In this video, we present a novel technique of ulnar collateral ligament reconstruction utilizing a 3-strand Palmaris longus autograft to create a hybrid linear construct. The authors have no pertinent disclosures. The surgeon may utilize a Palmaris or gracilis autograft harvested for their preferred technique. On the back table, overall graft length is measured, with an ideal measurement of 150 to 170 millimeters. The tendon is then folded over to create a 3-strand graft. This is also measured with an ideal length of 50 to 60 millimeters. If the triple graft exceeds 60 millimeters, this is trimmed appropriately to avoid bottoming out with graft tunnel mismatch. A number 2 orthocord suture is used for graft preparation. The ulnar end of the graft is first prepared, with the suture entering through the distal looped end of the graft while also securing the central and separate limbs between the loop. These 3 strands are then secured together using the Collateral type technique for a length of approximately 10 millimeters. 2 limbs of the graft now remain opposite to this previously prepared end. One is a single strand and the other is a folded over double strand. Each is prepared in a Collateral type fashion approximately 10 millimeters in length. These 2 strands will serve as the humeral end of the graft. The graft is remeasured to ensure length of 50 to 60 millimeters and then sized on each end for later tunnel preparation. The operative arm is placed in abduction and external rotation for best access to the medial elbow. An approximately 7 centimeter incision is made from the medial epicondyle distally in line with the native UCL. Dissection through the underlying subcutaneous tissue is performed. A white stripe within the flexor pronator mass in line with the UCL can typically be identified, indicating the appropriate interval between the 2 heads of the FCU muscle, and incised in line with its fibers. The FCU is then bluntly dissected with use of scissors followed by a key elevator to expose the underlying UCL. The ligament is incised longitudinally along the central aspect to allow central placement of the graft and later imbrication of the native UCL. The sublime tubercle is identified for preparation of the ulnar tunnel. A 2.4 mm guide pin is then placed at the central aspect of the sublime tubercle, with the tenodesis reamer typically 1/2 mm larger than the sized ulnar end slid free over the guide pin. The margins of the reamer are assessed to ensure it does not encroach to the articular surface or surround anterior and posterior cortices. Once satisfied, the tunnel is then reamed to a depth of 20 mm, careful to obtain a trajectory parallel and not toward the articular surface. A 15 mm in length biotenodesis screw the same diameter or slightly smaller than the graft is secured to the ulnar end and inserted within the tunnel. The integrity of fixation is then tested by pulling on the graft, lifting the arm off the table multiple times. If there is any concern regarding fixation, the screw is removed and upsized. A knot is then tied with the suture ends. Attention is turned toward the medial epicondyle. Dissection is performed behind the epicondyle for visualization of the drill tunnels and later knot tying. Scissors are used to enter the fascia adjacent to the bone on the posterior aspect, with muscle elevated utilizing an elevator. In a similar manner to the preparation of the ulnar tunnel, a guide pin is placed at the central aspect of the native UCL origin and the corresponding reamer slid free over the guide pin. The tunnel position is assessed and adjusted as needed to avoid encroaching too medial, which may risk fracture. Once satisfied, the tunnel is reamed to a depth of 15 millimeters with a trajectory that would exit at the posterior lateral aspect of the medial epicondyle. Potential for graft tunnel mismatch can be assessed, although rare, and tunnel deepened or graft trimmed. A 2 mm drill bit is then used to create 2 tunnels, drilling from distal to proximal through the previously reamed socket, with a bridge at least 5 mm apart at the posterior lateral aspect of the medial epicondyle. At this point, a Houston suture retriever is placed through each drill hole, anterior to posterior, with a looped end of the passing stitch retrieved from behind the medial epicondyle. Each of the 2 limbs of the graft are brought through the tunnel using the passing sutures. The elbow is then placed in 30 degrees of flexion and bear stress, and the sutures from each graft are tied together. The knot is created deep or lateral to the ulnar nerve, preventing any postoperative irritation. The native split UCL is then imbricated over the graft using interrupted ovical suture. An examination of the UCL reconstruction is then performed to assess restoration of tension. The elbow is ranged to ensure full motion. The suture tails are trimmed and the wound thoroughly irrigated. The fascial interval of the flexor pronator split is closed using ovical suture. Layered closure is performed and the patient placed in a well-padded posterior slab splint. Our postoperative protocol is included within the technique text of this article.